So can I just give a quick introduction? Obviously not about Ahmed, because Ahmed is one of the radiologist who's been heavily involved with the Ross program. We came across this because literature has showed that if you have a discrepancy of more than 2 to 3 millimeters between the pulmonary valve annulus and the aortic valve annulus, then either the Ross procedure, the long-term results are not great if you don't use an annuloplasty. So me and Mark were very pedantic about knowing how big is the aortic annulus, so we had all sorts of sizings from our imaging cardiologists and from Ahmed about perimeter, area, derived annuli, and then when we measured it with the HEGAR dilator in theaters, it was completely different. So we approached Ahmed and we're like, whether we gave him all our HEGAR dilator data to see what is the most accurate way of sizing, and I think he's come up with some great work. Thanks, Ahmed.
Thanks, Omar, and thank you for the kind invitation. Good afternoon, everyone. I think that I'll try to be quick as possible because Omar has showed all the good CT images that I was going to show you. But as you all may know that CT now is the gold standard in measurements of the aorta, definition of the geometry of the aorta and the leaflets, the annulus measurements before TAVI, whether the patient will receive a TAVI or a surgical approach. Also on the right side in the pulmonary route, we could simulate the stents and predict whether there is going to be any paravalvular leaks, the size of the stents. But as Omar mentioned, in Ross, it's a different scenario. We are comparing or trying to detect any discrepancies measurement-wise, geometry-wise between the aortic route as well as the pulmonary route, or compared to the pulmonary route in the same patient. And the geometry of the aortic route is different than the pulmonary in general, and in bicuspid routes is different because of the fibrosis, delayed development of the aortic roots, and sometimes or in many cases it's rounded compared to the pulmonary route, which is usually an oval shape. And there is one of the diameters, which is the AP diameter in the pulmonary route, which is usually large, which sometimes creates a kind of discrepancy in the route measurements. And this misled to excluding some patients from CT perspective to have or to be indicated for the Ross procedure. And as Omar mentioned during the MDTs, from this point there was the idea to go through retrospectively, to go through the cases that received the Ross procedure in LHCH, and to try to study and probe the parameters, the variables, the diameters that correlate or best correlation between the aorta and the pulmonary, which diameter is correlating better, and this in comparison or in correlation to the HEGAR. So we decided to measure in the aortic root side, we decided to measure the diameters. So the longest diameters, as you may see in this image, the two longest diameters, the area, the circumference. And in the pulmonary, we decided to measure it in 3 different levels in order to see which level is correlating to the best with the aorta in the CT images. And then we would correlate this to the HEGAR to see at which level is the best to measure the pulmonary annulus measurements. As you may see here, is this one of the levels is at the lower aspect of the cusps, here as being presented as the dark or the black line, and in the CT as the orange line, which is at the lower aspect of the 3 cusps of the pulmonary. And level 2 is at the ventricular arterial junction or the ventricular arterial trigone, here presented also with the orange line in the CT. And the last level in the pulmonary area was 4 millimeters below the cusps. So in another word, it's 4 millimeter inside the RVOT. And in every level, we measured the longest diameters, we measured the area, and we measured the circumference, and we compared all the variables together and to the HEGAR. The Excel sheet is kind of large one, so I will try to focus on the striking results in the next few slides. So comparing the aortic root, HEGAR to CT, we found that the HEGAR is best correlating to the longest diameter or to the average of the two diameters. But it was not correlating, or it was significantly different from the shortest diameter. And when it comes to the pulmonary, so the pulmonary HEGAR to the CT, we found that it best correlates with the shortest diameters in the CT and not to the longest. And we could filter out level 3 because there was a statistically significant different numbers between level 3 measurements and the HEGAR. So the shortest diameter, HEGAR to CT, level 1 and level 2 was correlating together. On the CT level, we found that the average diameter, aorta to pulmonary, at level 1 and level 2 are well correlating together. So we could, before excluding any patients or saying that there is a discrepancy, we need to confirm the average diameter of the aortic root and the pulmonary at level 1 and at level 2. So in conclusion, or to summarize the best results, that average diameters of aorta pulmonary at level 2 was well correlating or statistically similar, and at the aortic root, HEGAR to CT, the best way to do it is to take the average of the measured diameters on CT and to correlate to the HEGAR. And when it comes on the pulmonary root, HEGAR to CT is going to be the shortest diameter. There are some other potentials. I will fly through the other potentials from CT. We could detect calcifications in the pulmonary area or measure the calcium score in the aortic area to determine the severity of the aortic stenosis. We could detect whether it's a bicuspid or a tricuspid. On this side of the panel, we could see this is the interatrial septum. Non-coronary cusp is fused to the right coronary cusp, and this is the left coronary cusp. We could also measure the aorta or see or detect any aortopathies associated with bicuspid aortic valves. And as Omar mentioned, one of the areas that is kind of unclear now its significance is the septal perforators to the harvesting area of the RVOT. And we would like to have some feedback. What is considered to be significant distance-wise and size-wise of the septal perforators in anatomical relation to the RVOT? Post-operatively, also CT, I think, could detect any dilatations of the neo-aorta or any stenosis in the pulmonary conduit. For example, in this patient, this is the MRI in 2013 and this MRI in 2017 of the same patient. And here there is an increasing jet of the aortic regurgitation that was discussed in the ACHD MDT, but this patient is from outside our trust. Thank you very much, and if there's any questions.